Hello, everybody, and thank you so much for joining us for the Friends of the Farm lecture series. My name is Candace Hawes, and I want to thank all of our viewers and all of our customers from the pharmacy, from the pottery, from Natural Healing Center, as well as all of our friends watching from across the world. Today, we have one of my favorite guest speakers, Dr. Codi Peterson from the Cannigma, back with us again, and we're talking about a very interesting topic. Have you ever wondered why THC is one of the only cannabinoids that creates a psychoactive effect? And what really happens with our endocannabinoid system in our brain to cause this pleasant side effect? Our guest speaker today is going to talk about just that. Dr. Codi Peterson, Pharm.D, MS, is Cannigma's Chief Science Officer. He's a practicing pharmacist with a passion for cannabis-based medicine. Given his diverse pediatric pharmacy experience and knack for educating, he shares his knowledge whenever possible, and he is very generous with his time in educating people. Building on his experience teaching healthcare professionals about pharmacology and pharmacotherapy, he aims to educate as many people as possible about the medical potential benefits of cannabis. I really enjoy it when I get to work with Dr. Codi. He has a great way of explaining the intricacies of our own endocannabinoid system and how it interacts with cannabinoids. And I always learn a thing or two from him. Even after being in this industry for 20 years, I still learn new stuff from Dr. Codi. So with that, thank you so much for being with us, Codi.
Thank you, Candace, for organizing all of this and everything, all the work that you clearly put into this well-produced presentation. It's fun to be back. When you look at the people who've done the other Friends of the Farm or previously the pharmacy lecture, I'm among good company and really excited. So yeah, let's just get started.
Yes.
I've already been introduced. That's me. We're going to explore THC pharmacokinetics. I'll be honest, as I dove into this topic, Candace and I brainstormed what I wanted to talk about. Originally we were going to talk about sort of the pharmacology of THC, and it turns out that's just such a big topic. We don't have enough time. So I focused in on the pharmacokinetics of THC from the joint to your brain and beyond. Where is THC going? And then what are the nuances of this process that we want to learn about? So that's the focus of our talk today. But first, and I apologize, I converted to PDF PPT right before I sent this to Candace, and you can see there's a little bit of formatting problems. But right there is my social media handle that I want you to follow. That's me, Cannabis Pharm.D, and the Cannigma. You're going to learn a lot if you follow those two accounts, and also you'll be connected to me, and you can learn about all the other things I like to teach about, not just pharmacology.
One second, doctor. Actually, let me put on the PDF version because that's actually there's two versions. I have the PDF and the
Oh, that could be helpful. Yeah, hopefully
this one's going to be better. Sorry about that. It won't have
it's
any.
Okay. That's great that you can just flip it like that. I hope that it fixed
Big marker.
Look at it. Hey, yeah. You know what? Shout out to Big Marker on that one because that is handy. Okay, thank you everyone for coming. Follow these accounts. I know you're multitasking right now. You're probably scrolling. Really easy to just hit search and type those two in there. Okay, great. Next thing I want to talk about is what we're going to learn about. These are just questions to get us learning. This is not a test. Don't stress. But when we consume cannabis, where does the molecule go? You smoke this herb and you get this high. And, in the process is how does the drug travel throughout the body? What's the right dose of cannabis? And when you say right, what does that really mean? How do we determine what that dose is and why has it been so hard? And what are some obvious variables that make cannabis dosing so unique? It's not a pill, right? And pills are regulated in a way that cannabis really isn't, particularly the non-marijuana type. And we really we have to figure out and treat it a little bit differently, like a natural substance. How cannabinoids or the things inside cannabis are transformed by the body. And what are the implications of that? How does that affect you? How does it affect me? And could it be different? And then what patient genetics, just innately what's inside of us, can that be altering the way we experience THC, CBD, side effects we experience, and more? Okay, so these are the questions I want you to frame our conversation today, but I really don't want you to fret about the answers. Okay, so pharmacology is the study of drugs. I put together this little infographic taking together the three sort of pillars, the core concepts of pharmacology. And those core concepts tend to fall into three general categories. the study of drugs is pharmacology, but the study of how drugs move throughout the body, or what the body does to the drug, is called pharmacokinetics. Pharmacodynamics is actually how the drug has effects in your body. So what's happening at the cellular level? Where is THC acting with the receptor? You'll notice we're not going to talk a lot about receptors today, even though that's always what I'm yammering on about. What you'll actually find today is we're talking a lot about enzymes, the metabolizing, things that transport things. So that's because we're studying today not pharmacogenomics either, which is the study of how our genetics change all these other things, how drugs affect us, but rather how today we're studying pharmacokinetics, how drugs are moved or transformed throughout the body. Now, pharmacokinetics, as I said, is the study of how drugs work and move throughout the body, what the body does to the drug. Not when I take the drug, it does this, it makes me feel this, it changes my temperature, it makes me cough, it helps my blood pressure. None of that. What is the body doing to the drug to identify it and really get rid of it? Because anything the body identifies as foreign, its primary objective is to dispose of. So ADME is the 50-year-old or 60-year-old acronym in the world of pharmacology. And again, I'm a pharmacist by training, so I had 4 years of pharmacology training, which is not a PhD, who does even more than that. But what I really what my expertise is in translating this information and trying to help you understand. So I'm going to try to boil down a very complex 60-year-old science into something that I can fit into 40 minutes for the average person. So bear with me if I make a few assumptions. So ADME, A-D-M-E, is absorption, the distribution, metabolism, and elimination of drugs and substances throughout the body. It doesn't have to be a drug. What is a drug anyway? It's a simple chemical, and there are simple chemicals that make up the world around us. So it's a little bit nuanced in what a drug is. But for our intents and purposes, we're going to be talking about one drug in particular found in one of our favorite herbs. That is the THC molecule inside of cannabis. So we're going to talk today about THC metabolism, and you can see here from the Cannigma, which is indeed where I spend a lot of my time in the cannabis space, trying to educate consumers around what cannabis medicine. We have this sort of simplified graphic of what's happening when you smoke a joint. The THCA in the plant goes ahead, turns to THC, it's transformed, moved throughout the body, and eventually eliminated. So I ask you, if we're going to talk about pharmacokinetics, we're going to talk about delivering medicines. If we had a 220-pound man who smokes a 2-gram joint, Candace, that joint is 15% THC. How much of that THC in the joint gets into the man's bloodstream?
Oh man, that's a good question.
It's a pharmacokinetic question is what it is, and really it's an expression of bioavailability. How much of a drug delivered is going to get into the blood? It's a question we ask about all sorts of medicines, and in the pharmaceutical world, we tend to have an answer. This is the question we'll come back to later. That did not turn out the way I was expecting, Candace. I don't know what happened to that slide. So funny. Okay, I apologize. That's on me. I should have sent them earlier. So the rapid onset so we're going to talk about ADME of the drug, right? So marijuana pharmacokinetics, ADME is absorption, distribution, metabolism, and elimination. This is absorption. When we smoke THC, really THCA in a joint, we get a rapid absorption of that THC via the lungs. So we get movement across the cells that make up the lung tissue, which are normally meant for exchanging gases. And the smoke carries in it particulates that are THC droplets that have been heated to a very high degree at the end of a joint. Now, that delivery mechanism, delivering through the lungs, has a very rapid onset, as most anyone who's listening to this talk and smoked a joint knows. Very rapid onset. And a quite short duration. Again, anyone who uses cannabis regularly will tell you the real intense experience is really in the first 30 minutes of smoking cannabis, and the rest is a bit of a calm down. Albeit, some people experience a little bit longer than others. Now, when we smoke cannabis, generally speaking, the literature has looked at how much of this THC do we get, and the truth is it's highly variable. 10 to 50% is what's been found. 10 to 60 is the general range, but it can even be wider if you look at enough studies. 5 to 65, and this is for inhalation. Okay, so bioavailability is how much drug of what's dosed actually gets into the body and blood. Now, why is it only that bioavailable? Well, there's a lot of reasons, and we'll get into some of them later, but one of the reasons is you're not actually delivering a lot of that THC that's burning to the lungs. A lot of it is going off into the air. That's called side stream smoke, and it's estimated up to half of all the cannabinoids are lost just to side stream smoke. Okay, that's absorption of THC. Now, when we look at distribution, D in ADME, what we see is a process that starts simultaneously to absorption and continues constantly until eliminated from the body. So I'm not talking about a step in a series of 4 steps, ADME. As soon as the drug begins to be absorbed across the cellular membrane of the lungs, technically the process of distribution has already begun. The drug is distributing through the tissues of the body and is now going out into different cells. In particular, because the lungs are designed to transfer oxygen into blood, that's where most of the cannabinoids are going to go. They're going to go rapidly into the blood, and that's what we see. We see from the lungs, movement of the THC into the lungs, across the lungs into the blood, and then really that goes all throughout the body. It goes in one place in particular that likes fats, though, your brain. Your brain is composed almost entirely of fat, and so when THC rapidly distributes, it goes to the brain and your organs. And it goes there very quickly within a matter of minutes. Over that first 30 minutes, we get a shift from the blood to the brain, and then it begins to go back out. We see a redistribution out of the organs and out of the brain into our fatty tissues, where it tends to be stored and then secreted more slowly processed and eliminated from the body. And you can see here from our friends at Cannify, and our friends in particular, Dr. Linda Klumpers, thank you for giving me permission to use your lovely imagery. You can see that THC finds its way into the blood and then into the brain and then into the fat when we smoke it. Now, this is a slightly different path that the THC will take when we take edibles, and we'll talk about that slightly today. It's a topic that's been talked about quite a bit in the industry, and I think a lot of people are aware. We'll get there. Okay, so that's the distribution of THC, but it's really a reflection of what is going to be happening. This distribution of this fat-loving, fat-soluble molecule known as tetrahydrocannabinol, delta-9, typically when you find it in the plant. These fats love fats. This is just a theory, or something in nature that we know occurs. So these fat-soluble THC molecules and metabolites in our body rapidly go into the brain and the blood, and then they shift and go slowly into fat where they're stored. So on the right-hand image, you can actually see that as someone inhales THC, the cannabis smoke from the marijuana cigarette, the THC is rapidly moved into the blood, and that THC is then distributed to the brain and high perfusion tissues like your muscle and your kidneys and your liver. And then it's slowly moved into these low perfusion tissues, or really our fat is where the THC tends to go. And that's why it lingers so long. So you can see published on one of the articles that I reviewed on the Cannigma on the left-hand side of the screen that blood tests, even after a single ingestion, can linger for up to 36 hours. Well, you can see here on the chart on the right that at 36 hours, there is still some THC lingering in the person's blood and body. And this has to do with it going to the fat and then slowly being released back in. Remember, this isn't a one-directional pathway. Everything in flux and in movement. Biology is amazing. And so this whole thing in its end result means that you stay positive for THC or even more THC metabolites for a really long time. Drug tests are inherently biased towards these fat-soluble molecules that linger in our body. Okay, so metabolism, we're on to the M of ADME. There is a a difference between what happens here when we smoke and what happens when we take edibles. And again, from our friends at Canify, what we took is we took the THCA molecule found in high THC cannabis, type 1, aka marijuana, and we lit it on fire. We literally lit it on fire, oxygen and matter interacting at 2000 degrees Fahrenheit, vaporizing the cannabinoids behind the flame, and that's delivering the vapor of the joint. Now, in that is delta 9 THC, which is going to be absorbed and go through the whole thing we just talked about. Now, once it gets into the body, though, the body says, hey, that's not mine, right? The body does not see THC like an endocannabinoid. The body sees an endocannabinoid, says, I know what that is. I have a reason to get rid of it. I might keep it around. I might use it. When it looks at THC, it says, we got to get rid of this. This is from a plant. We don't know what to do with it. Let's get rid of it. So it metabolizes it, okay? And when we take that via the lungs, we actually skip the liver, which is our primary filter to protect against these things that are not normal to us. Okay, when we skip the liver by taking something through our lungs, which is only somewhat normal, right? If you think about we're the only animal who be smoking things. Let's just say that. Everybody eats things, but only we're smoking. So anyway, by doing this, we get less of this edible effect, less of something known as 11-hydroxy-THC. And this is the really big differentiator. Again, I talk about it a little bit more later in this talk, but this has been talked about at length, and you can read a great article on it at the Cannigma that was reviewed by me, and you can kind of get a feel for what's happening here. All right, metabolism, though, this occurs in many tissues, right? So this is why you don't get 11-hydroxy effects when you smoke, because by the time the THC makes it into your organs and your tissues and all that, a lot of that THC starts to be metabolized. And it starts to be broken down, and it actually ends up not being 11-hydroxy, but this next molecule that you can see sort of in the center of the screen, which is 11-carboxy. Yes, it's that confusing. 11-carboxy THC is another breakdown product, and it's not psychoactive. So exactly, these are the liver enzymes, and it leads to this 11-carboxy. Thank you. I got to figure out how to use my little clicker.
On the very top, there's on the very top above the screen.
So drawing. Mm-hmm. There it is. Ooh, and I can go full screen there too. Oh man, now I just feel silly. Okay. So now that I have my full screen's attention, you can actually see that 11-carboxy down here is our metabolite that's formed that's not active. 11-hydroxy over here on the right is very active, and that's from your edibles. So I could draw a muffin, but they're just going to put an E. And so you see these very differing effects, whether you deliver the cannabinoid through the lungs or whether you deliver it through the GI tract. Now, here's another example of other organs being involved in ADME. Now, ADME, the last E stands for elimination, sometimes said excretion. And I like excretion because it's good for memory, but elimination is actually a better term. And that's for a number of reasons that are sort of above the level of our conversation today. But how does THC leave the body, Candace? You can cheat and look in the screen.
I guess we pass it like we would pass food, right?
We poop and pee cannabinoids out. Yes, these are not something that are recycled in the body or used for energy like the fats that might come from the breakdown of our endocannabinoids. These are actually considered abnormal, and the body says we got to filter these out. And so we pee some of them out, right? As detected in a drug test, we know that we can find the metabolites of some of these cannabinoids. A little bit of THC might go out in the urine, but quite a bit of the metabolites can be found in the urine, about 1/3 of your total excretion. But 2/3 you're actually pooping out. Your body turns these molecules into what's called bile, and it excretes it in through your liver's biliary system into the GI tract. And here's what's even weirder if we want to get into it. You can see I started to talk about this in the lower right-hand corner. We actually get enterohepatic recirculation. So this means your body has absorbed the THC, sent it through the tissues, started to metabolize it, sent it through the liver, excreted it into your bowels, and then drawn it back in and then sends it through the cycle again. And this is actually well known to occur with cannabinoids and numerous other medications. And there's also this distribution into fatty tissues that we talked about, really extending. So we only get the effects of smoking for 4 hours, but the half-life, which is what we use for many drugs in pharmacy to say sort of to estimate how regularly you would need to use it, is only, or is as long as 24 or longer hours. Okay, so we should see these effects much longer, but we don't. What's happening? Oh, it's getting stored in these fatty tissues and it's not available for the body to use. So that's another reason why we see this detection window that's very long, as it's going out and being stored away. And even more so, as THC is metabolized, it really likes to go hide in those tissues. Okay. What's next? After we went through all of ADME, I've got a pretty little picture. Remember, I'm on social media, so you can follow me and you can get these sort of pictures and updates and explanations. Sometimes I have a lot of time to give you a really wordy explanation. Sometimes other people have already done it better than me. This is one of those cases. Somebody did a lot of effort. This is actually an explanation of what's going on with ADME in pets. If you look at the article, The Role of Cannabinoids in Pain Modulation of Companion Animals. So looking at THC and CBD in your dogs and cats. That's the frame of mind the person who wrote this article in. But you can see we're talking about all of these things. We're talking about administration, routes, whether it's oral or inhalation. We're talking about distribution to the lung, the liver, the brain, or the fatty tissues. We're talking about metabolism through CYP enzymes and going through the liver. So you're learning about the study of drugs right now, and you're learning about it in hopefully a fun way. Okay, critical variables that affect ADME, and maybe the word critical is a bit overstated here, but these are all the factors to consider. And the number one is probably going to be route of administration, but we're also going to think about genetics of individuals. The chemical profile of cannabis recently made some news and how that might affect ADME. I can't wait to share that with you and kind of dispel some myths live on the internet. Concurrent medications. These are medications that you're taking alongside your cannabinoids. That can have an impact on how cannabinoids are processed by your body. Therefore, what's going to happen? Consumer experience. If you're a self-described pothead, you probably have better technique on your smoking than somebody who doesn't. And then your metabolic health. We know that we talked about adipose tissue, excess body fat can change how much cannabinoids affect us and how long they linger in our body and things of that nature. So there's a lot of things sort of all intertwined. Another thing about metabolic health is what you ate with your edibles. So really, there's all sorts of things that affect the absorption, distribution, metabolism, and excretion, elimination of drugs. Don't get me, pharmacologists. Okay. The number one thing that I wanted to talk about was route of administration. We could probably do a whole lecture series just on this. This is like the bud tender, bread and butter. That works out well. Topical, enteral. Enteral means GI tract delivered there. Suppositories or inhalation. These are sort of the 4 core ways that we can deliver cannabinoids. There are different ones, one in particular that people would argue I need to be including is sublingual. There's some controversy around that, but certainly that's a viable route as well. But just to touch briefly on each one, you've probably heard of lotions and creams and salves, but they have this transdermal thing too going on that you may or may not know about. We're going to talk about that. Then you have your enteral products you take by mouth, your edibles, your infused oils, or what's sometimes called tinctures. And Candace, you may or may not know this, but this is a really frustrating term for us pharmacists, because by definition, a tincture is something that's ethanol or alcohol based, greater than 10 or 20%, whatever it might be. And that term is now used to describe infused oils or even, concentrates that have been diluted, like that. So it had nothing to do with the tincture, but this is, the evolution of weed talk. It's great. So tinctures made its way because we used to use alcohol. It used to be the go-to method. And then everyone was like, we can probably just do the oil. It's a little nicer. But, lots of things to be said about extraction technology. And that's above or outside of my my normal realm. Okay, I hope everyone's enjoying the talk. I'm not rambling too much, but we got to talk about suppositories, an often overlooked but potentially really useful route of administration for a lot of people with a lot of ailments, female-related issues, whether it's related to menopause or related to polycystic ovarian syndrome and everything in between. There's so much that these suppositories might be able to help with, and they've been grossly understudied and mostly dismissed as a viable option. But I'm hopeful for the future. And then inhalation, smoking, dabbing, and vaping. Okay, so I like to distinguish this. This is a little pearl for anybody who likes following me. I like to sprinkle little nuggets of information. Smoking, really high heats, 1,000 to 2,000 degrees Fahrenheit, really hot. Okay, it's going to change things. It's going to just break things down. It's going to produce more aromatic hydrocarbons, which are bad. We don't want them. More fine particulate, which are bad. We don't want them. It's really hot. Vaping is a newer technology. It's the heating to a lower degree, only to vaporize water and the oil droplets involved. There's the dry air vaping and the pen vaping. Everyone sort of knows all of this. But then dabbing is the one that I like to point out. Dabbing's this in between that we've come up with, right? And there's not really like a set temperature for dabbing. It can go really hot, people can go really gentle and very low temp dabbing. But it still comes up to around like 400 or more degrees, which is about as high as you would ever take any dry herb vaporizer or higher. So you're actually flash vaporizing. You're going a little bit faster and potentially a lot faster. And in doing so, you're just changing a little bit. You're delivering cannabinoid acids, converting them very quickly. There's a few nuances to it, and I'll get to those in a second. I wanted to jump to this next slide where I talk about the challenges associated with those topicals and deliveries. So topicals can be great way to get people started, but they're not well absorbed, okay? So is that a good thing? Maybe. If you take other medications, it could be a really good thing. But in other cases, it might not be the optimal medicine. There's really limited data on both the topicals and especially transdermals. It's kind of gross how little actual published, available science we have on the topic. But people report really great local effects with topicals. I like them a lot. Especially for individuals on prescriptions or who are looking for maybe like a localized support. Suppositories, really limited absorption. The existing data on rectal suppositories, despite rectal being used for many other medicines that are lipid soluble, just like cannabinoids, say it's abysmal and it's not good and it's not worth it. However, anecdotal reports say it definitely does something. I've felt it. Both in my head, right? Like systemic absorption, bioavailability, and also localized effects. Obviously, we can talk about inhalation. I've already talked about it, but there's variable technique on what we're doing with this inhalation. How big of a hit do you take? Are you using a bong? Are you using a bowl? Is it a one banger? Is it a blunt? Are you wrapping it in tobacco? There's all these things to consider that really make this challenging to study and challenging to standardize, which is what I want you to walk away with this idea today is it's not that simple. There's all these considerations to get to. And then with oral medicine, enteral, these administering cannabinoids in this route has proven to be extra challenging. And it's one of the reasons it's challenging because there's a lot of barriers to getting the cannabinoids to your body in a predictable way. One thing is food intake. If you take CBD with food, you can have up to 4 times greater absorption of the CBD. THC has found something similar, not quite. You get slower onset, but longer duration if you take your THC with food. This is just one variable. Food in particular, fatty food, by the way. Okay, gastrointestinal disease, inflammation of your GI tract might affect the absorption of these medicines. And if that's the case, it can be even more variable and even more challenging. Another pharmaceutical concept, which I didn't have enough time to get into today, is going to be first pass metabolism. We kind of talked about it a little bit with THC. And this means on the medication's absorption, when it's first absorbed, is its first pass through the body in the liver. And if it's in the liver, if it must first pass through the liver, then it's undergoing first pass. And that first pass usually takes a lot of the oomph out of medicine. not all of it. Sometimes if we design it right, or if nature just so happens to be unique like THC, it can actually pack more of a punch in that metabolism process. And we see after first pass metabolism an actual increase of potency or activity of the THC molecule. So that's a really just fun fact about THC, and it's not normal in drugs, but it definitely occurs. So these are just some of the challenges. I can't cover them all. They're all, really complicated, but especially when it comes to inhalation, the heat exposure is a big thing that can really affect even, um, you know, what cannabinoids you're getting. It can even affect sort of that pharmacodynamic, what drugs you're delivering if you're smoking versus not smoking, etc. So barriers to absorption. Everything's a barrier to absorption, believe it or not. Your GI tract is a barrier to absorption. Your stomach acid is a barrier to absorption. You are made of barriers, and the reason is you had to live in this world before we knew what things were, and we could pass information along, and we knew, what not to eat and what not to smoke and all of that good stuff. So we have barriers. They protect our brain from the rest of our blood. They are protecting our GI tract from our blood. That's our liver. It literally, you must take all the blood that goes from the GI tract has to go to the liver first, just to make sure you didn't eat something that could cause serious damage, or so the body naturally filters in this way. So other than IV administration, which skips all the filters or most of the filters, right? There's no natural barrier because we were not naturally made to go IV. Medications can't all make it all the way to the bloodstream. There's always some sort of hindrance, some diversion, some breakdown in the process. The body's filled with these barriers. So whether you're taking it orally or rectally, or you're injecting the medication into your muscle, there's some degree of reduced availability. And inhalation most closely mimics intravenous because the body, again, we evolve. There's no barrier in our lungs that's made to be a not barrier. It's supposed to move oxygen. So that's actually the most similar type of administration to IV. Now, you can see this great illustration from Canify here talking about another barrier, perhaps the biggest barrier on your body, which is your skin. And your skin is composed of all these different layers, especially the epidermis, and the stratum corneum, which is the waterproof layer of your skin. It's the reason that when you put water on your skin, the water just sort of falls off. It's because you have this layer of waxy protection. It's made out of something very similar to your fingernails or your hair. And so that layer has to be penetrated with a drug, but most cannabinoids, without the right, let's say, environment, or without the right patch environment, can't do that on their own. So you need to use patch technology, transdermal technology. And the truth is, pharmaceutical companies have spent a lot of time mastering this and really figuring it out. It's a really useful delivery system. But cannabis companies have not done that same level of research. We have very little information on what's really making it into the blood or not. So that's a word of caution. The buyer beware seems a little drastic, but the truth is we just haven't done this level of studies, most companies anyway, to figure out if this medication is truly making it out of the local area and into the bloodstream. And that does matter, kind of, like in a sciencey way, in a like proof sort of way. But I would also argue that proof is a little bit in the pudding. And like, does this patch help you? And like, does it really matter if I can prove that it's been absorbed into your bloodstream if you say it reduces your back pain? Mm-hmm. That's a different conversation, but I think one that needs to be had more often in science. Okay, genetics and metabolism is a big factor in how pharmacokinetics might, or how the pharmacokinetics of how cannabinoids work in us. We can't control how drugs break down in our body. We were born this way, okay? There is a very different set of enzymes that can be found in some unique subpopulations, certain Jewish populations. But the one that really comes to mind, and it's going to be hard to see, but down here in the very lower center, I'm going to use my drawing tool. I don't want to do black, though. I want to do something a little more fun. I want you to look at CYP2C19. And if you look here in East Asia, you'll see something very different than the rest of the world. You'll see that in Europe and in Africa, the vast majority of the populations are green or gray. And you'll notice in East Asia, the majority of population is actually red or dark red. Now, what that means would be great if I could see my notes right now. But it means the light red means a slow metabolizer, and red means a no metabolizer. Okay, so while most of the world is able to has activity of this one enzyme that's important for breaking down even cannabinoids, but many drugs. While most of the world has activity, individuals in East Asia have extremely reduced activity in that enzyme. And therefore, if we give them drugs, maybe multiple drugs like cannabinoids and pharmaceuticals that interact with this enzyme, they're more predisposed to adverse side effects. And so these genetic conditions we've already started to identify in certain individuals predisposes them. There's a few other good examples throughout the graphic, but I want for brevity to move on. But this is touching on pharmacogenomics. So you remember when I started it, I looked at the 3 pillars. I couldn't actually take them all apart because they blend together to create one thing that we're talking about. But I really wanted to hone in on pharmacokinetics, which is why we're talking about metabolism, because metabolism is part of that sub-branch. Okay, just made the news all over the internet right now, Candace. You'll see it. CBD worsens the effects of THC. Have you seen it? It's been on social media that I follow and everything. Now, is it true? Yes, this study found this. That's true. Absolutely. And I'm not even here to discredit it. But I think we all need to just take a deep breath and realize that there are some things that we can predict might happen when we do certain things. And in this case, we delivered 20 milligrams of THC, a decent dose, to a healthy adult. And we administered either, it's kind of complicated, but either with no CBD at all or with 640 milligrams of CBD simultaneously, like right at the same time. And what they saw was a big shift in the way that the body processed the THC. So you can see in A in the upper left-hand corner, the yellow is THC alone. Okay, and the higher up we go on the vertical axis, the higher the concentration of the drug, you can see that we created much higher levels of THC in the body by administering it alongside a very large dose of CBD. And even more astoundingly, we see that we in letter B, I got to get my drawing tool out again. In B, 11-hydroxy, the psychoactive edible cannabinoid, you can see that we've produced very little of it with just 20 milligrams of THC, surprisingly little. But when we delivered the THC alongside a big dose of CBD, we got this big spike in production of 11-hydroxy. Now, this isn't a very large study. It was 18 people, but it was well done. It seems to be, nicely done, let's say that. And is it true? They found this. But what we know is that much CBD, that could overwhelm the enzymes. That's a big dose, a half a gram of CBD when people take, maybe 100 as a pretty significant dose. So when you do that, what could you be doing? Well, you could be interfering with the CBD or CYP activity, these enzymes that we're going to learn about in just a slide or two. And by interfering with those enzymes, you're going to shift what the body's going to do with cannabinoids. Now, the thing is at a lower dose of CBD, which this study did not test, whether this effect holds true and to what threshold, we don't know. Right. So if we in my opinion, I guess I should say, this study is a proof that when we overwhelm that metabolic system, the CYPs, we can really change the way the body's able to process THC. And that's a consideration. We learn more every day. I'm excited for it, but I don't think it proves that CBD doesn't have the stabilizing quality we think it does on THC. I don't think that's what this proved. Although the people who took both, the people who got THC and CBD did have some more increased side effects compared to the THC alone. Now, what is the CYP enzyme? I just talked about it at length. You're like, why is it sip? What is this? So cytochrome P450 enzyme. This is a fancy pharmacy language term, and there's really not a lot of great ways to break it down. So I'm going to try. What I've got for you here is a picture of all the metabolic things that happen in the body, in particular happen in the liver, but happen all over the body. Okay, so that's what your picture that you're looking at. Now, where we're specifically focusing on something known as phase 1 metabolism. Okay, it's sort of like the most important phase, maybe the most we know most about. And look right here, it's CYP metabolism. Okay, now, phase 1 CYP metabolism. Why do we care? Because this is what cannabinoids go through. This is what makes your 11-hydroxy. This is what we were just referring to. But what does this have to do with everything else? All of the things, all the drugs, 80% of pharmaceutical drugs are metabolized through this same system. And what that means is the cannabinoids, if they can overwhelm our systems, if we can have drug interactions, then they can have implications on other meds. And we see this not with just this herb, which we do see with CBD in particular. THC is a little more docile in this respect. But what we do see with other plants and other fruits is similar functions. So if we eat grapefruit, we can see an inhibition of the same enzymes that we inhibit when we take CBD. Why? Because these are plants and the body it has the same mechanism to take care of plants. It knows what to do with these types of molecules. And this is how it breaks them down. So when we inhibit CYP, as you remember, it's involved in phase 1 metabolism. When we inhibit it, when we slow it down, we can increase the level of other drugs and other medicines. And this is why some people who are watching right now probably take medications for their blood pressure or maybe for other conditions that on the label it says don't take this medication with grapefruit. And you're like, why would that matter? It's because, ready for this, y'all? The flavonoids, yes, the flavonoids you think of with cannabis, the flavonoids in grapefruit and green tea are actually inhibiting CYP enzymes in the same way that CBD does. And what we find about both of these molecules is they also tend to be pretty healthy, right? We tend to see these antioxidant effects and things of these nature from these molecules too, flavonoids that are found in tea. So it's not bad that these fruits do that. What I'm trying to do is make it feel a little more normal, that things that are interacting with our bodies are happening all around us. And these are just considerations we should have with everything we do, especially when combining it with pharmaceuticals. So we talked about phase 1 metabolism in our lecture today. If you guys want to come back to Dr. Codi's pharmacology lecture, talk about phase 2, or my favorite, we could talk about metabolism in the brain. If you see in the lower left-hand quadrant there's something called MAO. You can MAOI, or no, MAO. It's monoamine oxidase, and monoamine oxidase is what breaks down serotonin, and it's also what's delivered as the second component in ayahuasca. So there's all sorts of things with metabolism and drugs that we can get into, but today we will stick to cannabis and move along. That's a CYP enzyme. They're all over your body. They can take care of all sorts of different things. Smoking cigarettes can upregulate certain CYP enzymes. Taking CBD can inhibit certain enzymes. Even smoking cannabis or marijuana can increase something known as CYP1A2. So drug interactions. We just talked about the baseline knowledge for drug interactions. We're going to talk a little bit about them now. There's 2 types of drug interactions, believe it or not. And those, we can categorize them, ready for this, into 2 general categories. You could probably put them in 3. Pharmacodynamic and pharmacokinetic. Makes sense. Okay, so each one is different. PK is pharmacokinetic. So if you look here on the left, THC, we have limited pharmacokinetic interactions. THC doesn't mess with the way that a lot of other drugs are metabolized or move throughout the body. Really, it's pretty hands off. It kind of knows what it likes to do. It likes to find the CB1 receptor and flip that switch, okay? But when we look at pharmacodynamic interactions, what is the drug going to do to me? We can actually see a lot more drug interactions from THC. So, for example, if you take anticholinergic medications for your urinary incontinence, let's say, and you smoke cannabis that causes dry mouth, those are going to synergize, and you're going to have really bad cotton mouth, so bad that maybe the next pill you try to take gets stuck in your throat, and then we end up going down this whole medical problem, right? So that's a pharmacodynamic interaction. Sleepiness. Did you take your sleeping meds and take a puff of your joint? Was that the best decision? Or did you then need to walk up the stairs and now you're feeling dizzy and lightheaded? Now, those are pharmacodynamic interactions, not really the talk today. So THC gets a bit of a pass in my lecture. Now, if you go over to CBD in the middle, CBD does not get a pass. In fact, it's a very promiscuous molecule. CBD goes into every enzyme's pocket and doesn't mind interacting with it, if you know what I mean. I don't even know what I mean, but CBD does inhibit and interact with a lot of different CYP enzymes and really some other enzymes in that algorithm. But we're going to, again, for simplicity, leave it at that, including 3A4, the one that grapefruit plays with, 2C9, 2C19, 2D6, 1A2, and many more. Okay, so a litany of enzymes, and those enzymes are responsible for doing all sorts of stuff, including breaking down the food we eat, but also taking care of the medicine we eat and maintaining balance and homeostasis throughout the body. Do a lot of important things. So CBD is highly implicated in drug interactions. We'll get to that in a second. What dose? Sorry, y'all, we don't know. We don't know what the dose is. It's going to matter. I wish I could give you more guidance. Case-by-case basis is what you'll hear me say over and over again. Okay, other cannabinoids. These are really cool. CBGs, a lot of hope, cannabinoid acids. I'm really excited about all of this. We just don't know very much. Like, there's definitely going to be some stuff that comes up, and we're going to be surprised, and we're going to learn more. But there's not enough information in at least not in the sort of public science space. But there's a lot of excitement and a lot of need for it. We just need some funding. So all you venture capitalists that I know are watching right now, you just send your money to the research institute, and we'll get those studies kicking off. Okay, drug interactions. Drug interactions are real, and when they happen, they can be mild, they can be somewhat severe, they can be life-threatening, and very rarely they cause death. Now, does that happen with cannabinoids very often? Very rarely. Very rarely. We're fortunate to have a very safe herb, right? No overdoses from THC. CBD, got to take quite a bit before we start to see, stress on the liver. It's generally a pretty safe substance. But we do know there is this broad potential for drug interactions. And CBD may interfere with the established phase 1 interactions, as we talked about the CYP enzymes, and it may deal with some of those phase 2, those other quadrants I showed you earlier. But here's a good example out of a new study. This is actually a study focused specifically for dentists. They were talking about, what medicines might your patient be taking and taking CBD oil, or can we give them CBD oil for their tooth pain? We got these anti-inflammatory benefits, and we know there might be some pain modulation. It might make sense. So they looked at what drugs that might be given in the dentist office or to these patients and what interacts. And you can see that some common medicines that you wouldn't think of interacting with your CBD popped up into mind for them, which is ibuprofen, Tylenol, lidocaine, benzodiazepines, Xanax, antidepressants, fluoxetine, Cymbalta, all that. So there's a lot of potential interactions. Again, at what dose? At what frequency? How long have you been taking it? These are questions that have not yet been established, but we know that taking CBD, if it interacts with these enzymes, will inherently, to some degree, alter the metabolism of these other medications. Now, does that matter usually? No. Can it be beneficial? Absolutely. Imagine you're trying to use opioids for pain, and or even benzodiazepines for anxiety. And you want to take less, and you can take CBD and your benzos and take less Xanax, that would be a good thing, yep. Right? So it doesn't have to be all bad that it interacts. It's just that it does. But sometimes it's bad. And we're going to learn about a case like that. There's a case report back from 2020, I believe 2019, published in 2021, that looked at cannabinoids and prescriptions. That's not true. Looked at one specific case of a cannabinoid alongside a prescription medication. And these combos probably carry a unique risk compared to cannabinoids alone. Why? Because drugs carry risks. And when we add inhibitors and changes to their metabolism, we increase that risk. Do we do riskier things? Sure. Every day we drive to work on the 405 or the 5. It's certainly more dangerous. But the case reports, this can still happen. This case report involved meloxicam NSAIDs which is like ibuprofen, a prescription sort of potent one, and CBD oil. Now, it's not characterized CBD oil. We didn't get a nice test. We just know that the woman reported taking it. After taking meloxicam for 5 years, began CBD, and within a month of beginning, or 2 months, I believe, of starting that CBD, this horrific rash shows up. It's called Stevens-Johnson syndrome, and I've seen it a couple times in my career at the hospital. It's always nasty. You don't want it. It can be life-threatening. It starts inside the mucous membranes, and it facilitates into this skin just literally falling off of your body. It's very, very traumatic. And you know, the doctors evaluated the situation, and you know, meloxicam has been associated with Stevens-Johnson syndrome, and this is a recognized risk with this medicine. And this woman who was taking it didn't realize that this risk could potentially be increased by adding in CBD oil. I mean, the report doesn't even mention the dose, so I want to be very clear. This isn't me raising the alarm bell as much as me saying, look, these are not inert substances. You're consuming them because they do things, and when using them alongside prescription medicines, we should be thoughtful and talk about these things. So that's just one really bad case. There aren't very many, but because of cases like this, the University of Penn State, the College of Medicine, the college, I think there's some pharmacy school involvement as well, working on this drug interaction review checker. So they published a report of high-risk medications that are interacting with THC, CBD, or a combo of both, and you can actually run the medications. There's one for medical professionals and there's one for the average person. You can go use this useful tool if you're worried about your medicine. Super helpful. I would recommend it. Is it perfect? No, but we got to start moving in this direction where we have open access, free information, and honest conversations about the risks and the benefits, and study the benefits and the risks, not just the risks. So we just need to really come around to this full open dialogue. Okay, so another factor I talked about that influences pharmacokinetics, and this one's hard to think about and you might not expect it, but you actually see cannabis consumer experience dictating how the person responds and how they report their effects, and also how much they absorb. Believe it or not, experienced cannabis smokers get way more THC into their blood than the novice smoker. And this is from holding their breath longer, taking a deeper inhalation. They have a tolerance to smoke. They're just not as gaggy. That doesn't burn as much. How many hits do they take? Or is it a 1, 2, 3 kind of situation? Like, where's the puff pass? Is it 1 puff or 2 puffs per puff here? The chronic THC increases respiratory volume. This is an interesting finding. Even though we, historically have thought of cigarettes smoking causing scarring in the lungs and reducing lung capacity. And we've seen this with cigarettes over and over and over again. It doesn't seem to be happening in our chronic marijuana smokers. And we actually see is a little bit of increase in total lung volume. Now, that's not inherently a good thing. It sounds good. It sounds like, oh, well, but the hyperinflation is not good. We just want optimal inflation. And we're still trying to figure out what it is. But work in the lungs, kind of bringing it in. And then we also know that THC has a bronchodilatory effect. Has been established. It relaxes some of the airways, kind of in a way that we see with albuterol. Not a replacement for albuterol. It's just simply that these are the physiological effects, the pharmacodynamics of THC interacting with the cannabinoid receptors. Again, next talk. All right, coughing. This is interesting, and this is a bit of a throwing it out to the crowd, y'all. So if you're listening, I want to write an article on the Cannigma about this. Coughing, does it affect how high you get? I think it does. People report that it does. You get higher when you cough. So if you're watching this talk, please comment below. It's on YouTube or wherever you're checking this out. Tell me your experience. Should I write an article on it? I want to be like a leading lung expert and give the real report. Because there's pressure. The lungs are pressurized air sacs. It's actually negative pressure. So when you pull down on your diaphragm, air is actually pulled into the lungs. You're not actually sort of inflating them. They're inflating themselves because of the pressure you create in your diaphragm. Okay. Reported effects. The experienced cannabis consumers report different things. And so they know when they take cannabis. So it's kind of hard to distinguish and figure out if the pharmacokinetics and tie it into the pharmacodynamic experience. And then one thing that's really interesting is this natural titration effect that I wrote about here. The reason that's interesting is when new Colorado or University of Colorado research has come out, they found that cannabis consumers were kind of regardless whether they're dabbing or they're smoking joints or whether they're smoking bowls, they all sort of smoke to that same sort of level. There's not like this big disparity in drug levels in one type of consumer. When you look at people, you just say, hey, smoke to your contentedness. We tend to see people finding their way to sort of this happy medium and not this effect. So it's super interesting. Almost there. Metabolic health in particular, we're talking about excess adipose tissue, fatty tissue, particularly in the West. I think we're all a little guilty, especially post-pandemic. But this does have an impact on the way cannabinoids are stored and moved throughout the body. And could this have an impact on us? Certainly it could have impacts that we're not entirely sure what they are. But if you look at the two that I have an arrow pointing to, so this is A, B, C, D, E. It's a bit of a spin on ADME, but you can see that B is metabolism. So there can actually be changes in our altered level of CYP 450s. So being overweight can actually alter our metabolism, which may then alter the way that we respond to cannabinoids. And then also distribution. We know that a larger volume of distribution will likely require a larger dose, at least if you look at a larger picture. To achieve the same effect, because you've got what we would call a larger volume of distribution. So when the medication enters our bloodstream and is able to go to the fat, it's got a big tank to fill up as opposed to a smaller one. So metabolic health has a big impact on pharmacokinetics as well. Not a whole lot you can do there outside of obviously just trying to be healthy. And cannabis can be a great tool for that as well. The perception that cannabis and stoners are lazy and fat is just totally wrong. More and more data supports the idea that we're regular folk who like to be regular active, eat regular food, and do regular people things. So normal, right, Candace? Great.
Yep.
Okay, so I started the talk with talking about this joint and talking about this man who weighs 100 kilo, smoked a 2-gram joint, contains 15% THC. How much will get into the man's blood? Well, in that joint, 2 grams, 15% THC, there's 300 milligrams of THC in that joint. Sounds like a lot, right? If you think about your edible dose, you're like, kind of. But remember, only 10 to 30% will get into the blood. So now we're talking about 30 milligrams, and that's not as impressive. But that's only if we lived in a hypothetical world where a robot smoked your joint at a consistent measure in your lungs and your nutritional status was of an optimal human. The truth is we don't know. We don't know where it's going to be. This is why we can't get blood levels, or we can't detect blood levels and associate with impairment and all of this stuff. This is complex stuff, and it has a lot of variables, so many variables that we're not going to be able to tell you what your level is going to be after you smoke that. It's just not. That's not the way the pharmacology works in this case, not the pharmacokinetics. So that was a trick question. There was no. I guess it wasn't a trick. There was a right answer. It wasn't gonna make it anywhere. So
I paid for it on Stronghold. Yeah.
You're good, Candace. I everyone at the pharmacy. So anyway, some takeaways. I thought a lot about these, and I got a little pie in the sky here, so bear with me. But drugs are complicated, and saying indica sativa hybrid is not going to be enough to help us distinguish them, and that's not going to be enough to help a new user figure out how to best consume cannabis. So don't start with that question. The exact science isn't all that helpful either. Like my last example, 10 to 50% bioavailable. That's a pretty wide margin here. So where do we start? We start with one puff. We start with one half of the dose we expect to cause a psychoactive effect. And we titrate up slowly every couple of days or every couple intervals to get to a point that we want without overshooting. Because overshooting isn't going to harm you in most cases, but it is going to affect the overall tone of the system. And it can actually just make you increase tolerance and kind of work up quicker. So thoughtful and mindful consumption. Cannabis is an amazing herb. It has so much to give us, but without we still need to kind of know what it does. We need to know that it can drop our blood pressure a little, for better or worse, right? Whether that's a good or bad thing, we need to consider it. We can think about how these large doses or how when we how do I want to say this? When we take an edible, how it might affect us, or whether we take it with food, we now are feeling more empowered after this talk to come back and really try to leverage this information to optimize your experience. And that mindful, informed consumption will help you do that. Advancements, science is changing. It's changing fast. Most of the things that I cited here today were from 2019 or newer. Not everything, but almost everything. So, the real research and real products, looking at real genetics and real world scenarios is coming, and we need to leverage these approaches and blend them with the clinical trial approach. But we can't lean into this sort of, we're waiting on an FDA approved cannabinoid to tell us how this medicine works. And it's just not going to work. There's too many variables. We've already discussed them. And remember, we're only in the one bubble of pharmacology today. Haven't even jumped into the complexities of those other two bubbles. And so it's really too much to try to, use the old mentality to fix the modern problem. So I want to thank you again, you, Candace Haas Lopez, and Glasshouse Brands for supporting the Friends of the Farm, and then OC Normal, of which I am a member. And I want to thank the Cannigma for spotting me a couple of years ago and letting me come into the fold. And then Linda Klumpers for supporting a lot of the pharmacokinetic infographics here today. Those are on her website, Canify.com. Definitely worth looking at if you want to nerd out on the real. She's a PhD pharmacologist, not one of me Pharm.D pharmacologists. But really good stuff. Cannigma.com, at the Cannigma, Cannabis Pharm.D. And then if you want to email me, hit me up in chat. I'm open to doing consulting and all of that good stuff, or just educating. You want me to speak at your event? Great. Let's get me there.
Thank you so much. You did not disappoint, as always. You brought a couple things to light that I didn't understand and clarified, and a couple new things. So this was wonderful. Thank you so much.
I'm happy to educate. It's kind of my thing.
It is. I could tell that you have a passion for it. And watching the chat, people have really enjoyed this as well. They've loved the more thorough, kind of deeper education that we're providing today. So this has been wonderful. Do you have time for a couple questions?
Yeah, I'm not going anywhere. Where are you going?
Okay, cool. Nowhere. I'm happy to be here with you guys. So here's a couple of them. So somebody's asking, there's been studies to determine the difference in rate of metabolism, or asking, has there been studies to determine the difference in rate of metabolism of Delta 8 versus Delta 9 when both are present? And also, does the rate of change when homologs are at play, for example, like THCV or THCP versus THC?
Nice job. That was a hard question to read. I would have stumbled with it, and I have my master's.
It's a good question. Thank you, audience.
Jeffrey. Hey, so here's what we know regarding metabolism. Delta 8 and Delta 9 are going to go through similar enzymes, the CYPs. Now, it's not just one CYP that's able to do one thing. Even though it might have a preference, the CYP might prefer to do one thing. If it's too busy, another enzyme will come in and do it. It might not be as efficient. It might be a waste of resources, whatever it might be. The body will take care of it. But Delta 8 and Delta 9 look really similar to the body, exceptionally so. That's why they have such similar effects. And as such, I would expect them to have a very similar rate of metabolism. With respect to THCV and THCP, you are talking about a bit of a different question. And it is possible that those phytocannabinoids, and those are naturally occurring cannabinoids in the plant, they're just made in much smaller amounts, and only in certain varieties. Those homologs could have different half-lives and could last longer and have different effects, but they would still follow the same general principles that we learned today with respect to long time hanging out in the fatty tissues, rapidly moving across the blood-brain barrier, being in acidic form and needing to be heated before all of that stuff still applies. But as far as studies on that, no one has sunk any money into that specific study. If you were interested, you could try to go look at CBDV research, which has been done, but CBD is a different beast. I've talked about this in my other lectures. CBD and THC. THC has a rigid structure. CBD is sort of floppy, and because of that, it's really promiscuous. That's why so many proteins, and so it's going to be hard to make any extrapolations from that. So I almost take it back. You probably can't look at CBD.
Well, thank you for that really good answer. Another answer, somebody's kind of curious based on something you said earlier. What are some examples of some other things besides cannabis that are more potent after first pass? Are there other things, or is cannabis like the outlier that's special, that it gets more potent after first pass?
So in nature or period, like, is there like one more time? The question is I was looking for that. I didn't see it.
So it's from Andrew H. It's a couple down from the one before. So example of things that are more potent, like are there other medications that actually get more potent? I guess not more, they're intended to be taken one way. So it's like if you know.
Yeah, so this is a unique herb that has unique pharmacology, but it's not like there are many substances. What's going on with THC and 11-hydroxy is a process known as an active metabolite. And an active metabolite is a pharmaceutical concept that comes up with some regularity. Now, some substances do not have activity themselves, but have an active metabolite. Those are called prodrugs. But because THC has activity and 11-hydroxy has activity, this is just known as an active metabolite. And there are many other drugs with active metabolites. Now, this one's a bit unique because of the action of that active metabolite. 11-hydroxy, for reasons that are really still being investigated, not fully agreed upon, is more potent than Delta-9. It causes more intoxication. Affinity-wise, attraction to the receptor, pharmacodynamics, it hasn't been shown to be that tremendous. So they're still trying to figure out why it's more potent. It might have something to do with the way it's moved in and out past this barrier in our body known as the blood-brain barrier. And it looks like once it gets into the brain as 11-hydroxy, it can't get out, kind of. And so it might have to do with a pharmacokinetic interaction, and one that we didn't cover today because we only did phase 1 metabolism and not efflux transporters. But maybe we need to go to pharmacy school.
Yeah. Great answer to that very complicated question. Somebody's asked about getting ediblocked. I guess that's what the point, like where you don't get, intoxicated or don't get any benefits from cannabis. What do you want to talk about that a little bit? Like how people don't get psychoactive effects from edibles, like at normal doses, like maybe like why that might happen to some people?
Well, look, we're all different. I just explained all these this litany of reasons why this could be the case. And that could be increased enzyme activity because you're maybe one of these rare minorities who has that increased, you're in that green zone and have super rapid actions. I think the most common reason about the Eddy block, it's usually people are smokers. And if you remember that sort of XY axis where we see drug concentration in time, we get much higher spikes from smoking THC. And that's going to have a much different effect on the endocannabinoid system, bringing down its sort of baseline level of activity. So by the time we introduce the edible, which is at a much lower dose, remember there's 300 milligrams in that joint that you have 5 times a day versus that 10 milligram drink or 20 milligrams. I think a lot of people just really can't get past that threshold. But there are individuals who, for whatever reason, either aren't absorbing or just are chewing up, and that's a pharmacy lingo. Their livers are just really ramped up to get rid of that molecule for whatever reason, be it genetic, be it that they take a medicine that turns it up, turns the volume of that enzyme up, or just tolerance. I think all those are reasons. Cannigma.com, why I can't feel edibles. Just Google it, why I can't feel edibles, Cannigma, and you'll get an answer. I reviewed the article. You'll like it, I hope.
That's great. I actually have people say that to me all the time. Oh, edibles. I never feel anything off of edibles. So thank you for that. And I will actually point them to Cannigma. One of our other questions was, what is a really good place to get educated, more scientific information on cannabis? I would definitely say Cannigma. I was so impressed too with your guys' whole wall of education that you guys had at the California cannabis exhibit at the state fair. It was amazing. So I always point people to you guys. But besides the Cannigma, what are some other resources that you would suggest?
Well, I'd be remiss to not give a shout out to Linda Klumper's Cannify. She's got like how to find the right product or how to find the right, cannabinoid profile for you. So she's got a little quiz there, a nice little tool you can try. There's so many good places. You know what I tell people? Get on LinkedIn. Find the people that are talking about it, because the truth is, things are constantly changing. Even at the Cannigma, we're always talking. Something study will come out. Alana will text me, "Hey, do we need to update it? Like, hey, does this change things?" Like, because every day they're coming out. I cited that article I did today is less than a month old. It's all the rage. It's in the news just yesterday. I think I saw it on like national news or something unnecessarily deal because it wasn't that impressive. But like, this is what's happening because it was in JAMA, and that's the media cycle. So there's stuff changing all the time. Definitely the Cannigma. What else do I like to read in the cannabis sphere? I really like Terpenes in Testing. I like Analytical Cannabis, which is a magazine. There are a couple that come to mind. Oh, last one. You got to. Curious About Cannabis. Cannabis. I can share the link with Candace later. This is Jason Wilson's baby. I help him as a guest lecturer. He's doing a masterclass right now. If you really want to kick it up, if you want to take your education to like college level for 1/50th of the price, you got to take Jason's class. He's phenomenal, and like I look up to him. I've been on his podcast a couple of times, but like he inspires me. I got to be more like that guy.
That's wonderful. Those are a lot of good resources. So thank you for sharing those. One more question. This is a good question. What is the sublingual absorption? Like, what is the bioavailability of sublinguals, when you use them correctly, like under the tongue?
Candace, this is super controversial, and we were all on Clubhouse, and we were talking, and I'm talking to some of the most prestigious, well-known doctors. Dr. Patricia Fry comes to mind, and she recommends her patients use sublingual, and they get benefit from it, and they feel onset very quickly, and it's shorter than edibles. But that's not what the science says right now. The science generally, like I said, the available big science says that it's really pretty similar to taking orals. There might be a little bit of activity in the beginning, and I believe that. But most of this is going through the enteral GI tract. And this idea that it can go sublingually is usually derived from Sativex trials, which is the commercially available product for multiple sclerosis in 18 countries except for the US. And so this product was used, and it's a spray under the tongue. But when they looked at if you look at their studies, it didn't actually show that it was more rapidly absorbed in that way. It was just more consistent than taking it by mouth. So maybe by coating that area and allowing it to absorb a little bit slower from that space. So there's no agreement there. Now, the recommendation, if you go to the Cannigma, you can find some of these, and this is always a little controversial because it's hard to walk the line between what we know, what we say, and what's true and what's not true. I think we'll say that, onset start in the first 15 to 45 minutes, but don't expect it to be that full dose. Don't expect all those effects, because most of the dose that you're taking under your tongue is still going to go orally. You're swallowing most of that. I hate to tell you, oil is not just disappearing into your mouth.
It's your saliva, and you're swallowing it.
Swallowing most of it, not all of it, and there could be localized effects, especially if you're talking about cannabinoid acids or CBD. But like most of it goes orally. Enterally is the pharmacy term, and as such, that's where we're at. I don't know. I don't have a perfect answer.
The science is still out.
Yeah.
Good answer to a hard question.
It's a good question. Is what it is. It's just really difficult. I love this question from hear more about herbs and MAOI. I haven't covered this in another video. It's a totally different topic and probably outside the scope of Friends of the Farm, but certainly in my wheelhouse as a pharmacology nerd. So I'll add it to my content list and try to talk to you about that. The answer is there are absolutely herbs with monoamine oxidase inhibitor activity, and a lot of use for things like depressions or other. What else? Is it beneficial to hold your breath smoking herb? We got to talk about this one. Pharmacokinetics, drug delivery. Is it beneficial? Is it beneficial? Beneficial, no. And here's why I'm going to say beneficial, no. Because the longer you hold it, the more you're likely to get exposed to some of the bad stuff in the inhalables, the smoke, etc. Okay. So there's no consensus on this. You know, some people say hold it for 3 seconds. Some people hold it for 5. If you go to the Cannigma, before I was there, we wrote an article and, you know, we try to foo-foo it. It was only so done. You know, it's a nuanced topic. If you hold any medicine in your lungs longer, you are likely going to get some degree of more absorption, right? Just pharmacokinetics 101. However, the returns are diminished, and in particular when it relates to smoke. The cannabinoids that are vaporized are the heavier particles in that smoke. And heavy means they fall faster. They fall to the lung surface. So because cannabinoids fall faster and the bad stuff, the polyaromatic hydrocarbons, are floaty and light, the longer we hold it, the more likely those are going to expose us to. So we're finding a balance between giving ourselves a proper exposure to the cannabinoids and reducing our exposure to the harmful particles. There is no perfect answer. I wouldn't recommend holding your breath as long as you can, trying to maximize. Weed has gotten cheap enough where you don't need to do that, hopefully. And that thankfully, but I get why people are doing it, and I won't foo-foo the idea that you can get higher from holding it in. Obviously, that makes like logical sense, but to what extent and whether it's worth it is the nuance of the question.
Thank you. Very good. And then we have just one last question. And I think he just wanted for you to go over this one more time. But was the 11-COO THC from smoking, and was the 11-OH THC from eating? Was that correct?
So technically, they both get produced both ways. Okay. So just to clarify, but here's what I want people to walk away. And this was not I'll be honest, if I have a weakness in my lecture, this is probably it. Okay, so it was around the edibles and how to do it. So the edible high is induced from the psychoactive metabolite 11-hydroxy. Okay, that's OH. The carboxy, COOH, is the non-active metabolite that gets stored, and it's also what they look for basically in a urine drug screen.
Okay.
Now, the reason I want to point out, though, that they both get produced is we have these enzymes all over. It's just the ratio. We produce way more 11-hydroxy when we take an edible because of two things. It's got to go through first pass metabolism, but I kind of want to throw one more pearl in here for everybody at the end. First pass is not just the first pass through the liver. It's before that. It has to pass through the intestines. That's another barrier, right? Mm-hmm. I talked about it earlier. The intestines are one of the most abundant places for CYP enzymes in the body as well. Makes sense with what we talked about plants and everything. But that's another place where we're producing 11-hydroxy and we're being absorbed. And so that's another way that it's sort of cranking up in that first pass. So it is indeed the 11-hydroxy, the OH, that is the edible, very powerful psychoactive metabolite.
Cool. Thank you for going over that one more time. But this has been wonderful. You had so much great information. You're definitely passionate about cannabis and so educated about, all the different facets. And I love that you have this pharmacological background, and you've been trained in cannabis science as well. And you can marry them together and help people understand, all these concepts that can kind of be really difficult. So this was a wonderful presentation. Thank you so much for all the time that you put into putting this all together and for being here and staying a little bit extra and answering all the questions that we had, because we had a lot of great questions that got submitted. So thank you again, Dr. Codi.
Well, Candace, I appreciate it. And then maybe we'll come back for pharmacodynamics on the next one.
Yes, I would love that. And shout out to the Cannigma. I love what you guys are doing. Thank you to everybody that's spending their evening with us. I know that you guys all learned a lot, just like I learned a little bit more today. And we are hopeful that you guys had a great time tonight with us and that you were able to learn some information that will help you become better informed cannabis consumers, and that the information that we shared will help you find relief. With that, I hope everybody has a great evening. Thank you so much. And we look forward to seeing you on another episode of the Friends of the Farm Cannabis Lecture Series.
Thank you, everyone.